Welcome everyone, I'm Pospo and this is another webinar of the Monster Learning series, The Psychiatry of Pandemics. Last week I traveled all the way to Denmark. Of course I didn't travel to Denmark, I'm not Dominic Cummings, stay home zone, but we did indeed have Prof. Michael Eriksson Benros talk to us live from Copenhagen about immunopsychiatry and how Danish nationwide registers helped establish the link between immune-related factors and mental illness. This week, we take a sharp turn, leaving genes and cytokines behind, and we're diving deep into the mysterious and fascinating realms of philosophy, because the coronavirus did not attack only our cells, our lungs, and our brains, but ended up being a threat to our society as a whole. And that's why today's guest is not a psychiatrist, is not a pharmacist, or an infectious disease specialist. Most probably, he has never taken blood or requested an X-ray in his life, because he's a philosopher, a political philosopher to be more precise. Dr. Sridhar Venkatapuram, an associate professor in global health and philosophy here at King's College London. Sri brings health and social sciences together with philosophy and ethics in order to solve problems related to health equity and social justice. Most importantly, though, Sri is one of the few people out there with an equally difficult surname as mine, Posporelis and Venkatapuram. I'm already seeing typos all over the place. Welcome, Sri. How are you doing?
I'm doing well. Thank you very much for involving me in this.
Fantastic. So, Sri, let's start with the basics. So, philosophy, a Greek word, or in fact, two Greek words, the exact translation of which is the love for wisdom. So, though beautiful, it's a really beautiful word, I mean, the love for wisdom, but at the same time, it's quite abstract as a definition. So, what is the role of a philosopher in the modern society?
I think there's so many roles that a philosopher can play in modern society. Well, right now, what we are asking ourselves, at least in the UK, is what is a good government and what is a good political leader and what are the right and wrong things for political leaders to do. Political philosophy is meant to ask these fundamental questions about what is a good society, what is the role of government, what does democracy mean. I particularly work in the bringing together health and political philosophy and asking questions like how does health play a role in social justice and what do we have to do about health inequalities. So I don't think I need to ask for a job in this world. I think that there's plenty of work that needs to be done in trying to disentangle the problems and asking questions about what the right thing to do is.
I mean, since you mentioned the word justice, in your own book, Health Justice, you write that the capability to be healthy needs to be recognized as a basic moral entitlement in the same way as any other fundamental human rights. So how far do you think are we from making this happen?
Yeah, so I think the basic idea, the argument that I make is that when we think about health, we often focus on health care and goods and services. And what I want us to focus on is people's ability to be healthy. And that ability is a combination of both their conditions that they live in, but also their biology and also commodities. What we're seeing particularly right now in this pandemic is not that people are dying because they don't have a pill or an injection, but because they are not have the abilities to protect themselves from an infection. So it's now more important than ever that we try to start thinking about ability to be healthy rather than access to medicines when we're sick. In terms of how far we are from now, you can see just around the world which societies protect that ability of people to be healthy and which societies are not doing it, and particularly which groups of people within societies don't have that ability at all, and then they're dying and vulnerable. I think that that's the numbers don't lie. The numbers are telling us exactly who has the ability to be healthy and who doesn't.
Numbers don't lie, you're right. Now, the social determinants of health, meaning the conditions, where we are born, where we spend our lives. So these are tightly linked and formed by finances and money and power. And in fact, it's these social determinants that are responsible for the health inequities. So do you think that these inequities, are these avoidable?
Absolutely, absolutely. So one way to explain it is that I think that everybody understands that health is not determined by just access to healthcare, but also the conditions in which we live. But these conditions aren't just material conditions, it's the way that we relate to each other, the kind of stress that's created in the work environment, but also the politics at the international level. Just think about how the politics between different countries has evolved over the last few months and has actually impacted the way that epidemics are spreading in different countries. You can look at the way that different countries deal with these social determinants by the fact that in every society, health is actually distributed across a social gradient. That means that every socioeconomic class lives longer and is healthier than the one below it. And different societies have different gradients. So some are very steep and some are very flat. That tells you a lot about the way that a society is actually addressing its social determinants of disease and mortality. So I would say that you can see very clearly, not only in sort of the lower life expectancy of the population, but in the distribution of what's going on, is you can see how much the social environment is supportive or harmful for health.
So let's focus a bit now on COVID. So in a really interesting Lancet article, published this month in fact, so Richard Harsh and Vikram Patel propose an interesting question. So has COVID-19 subverted global health? So now they start the article by saying that by May 2020, in fact now, more than 90% of all reported deaths from coronavirus, they have been in the world's richest countries. Now, despite that, it is these richest countries that direct health policies worldwide, such as lockdowns and physical distancing. So, do you think that that one-size-fits-all approach was more harm rather than benefit?
Yeah, so I'm going to answer that in two parts. One is that our current picture of the world right now may not be where the world will be a year from now regarding the harm that this pandemic has caused. Remember that the infection started in China and the spread through international flight paths, right? So that's where the particular spread of infections. At first it went to the major urban centers, and now it's been moving to secondary centers, and it's moving into developing countries. So a few weeks ago, it looked like Africa and India were going to escape these infections, but it's too early. Before many pandemics, or in the pandemics in the past, we've seen that it takes time for these infections to reach these countries, and then it finds the most vulnerable and it settles there. And that's when it starts the numbers over a long time. The second part of your question is, did the policy, or are the policies that we've implemented in rich countries applicable to the poor countries? I think that what we're seeing is that these lockdowns that were implemented were incredibly devastating for poor countries, but they've also been devastating for rich countries. So we have to think much harder about, at every country level, what are the appropriate ways to identify the risk of infections and what are the policies that are relevant to those risks. The one-size-fits-all isn't good for anybody, and there's going to be a lot of debate from now on about what was actually needed and whether it was the right thing to do and what we need to do going forward.
So now let's scale down from between nations to within nations. The Lancet, April 18. In the United States, deaths due to COVID-19 are disproportionately high among African Americans compared with the population overall. Journal of American Medical Association, April 29. The Bronx, which has the highest proportion of racial ethnic minorities, the most persons living in poverty, and the lowest levels of educational attainment, had, guess what? Higher rates of hospitalization and death related to COVID-19 compared with all the other 4 boroughs in New York City. And certainly here in England, there's plenty of evidence that minorities have been hit way harder and die in greater numbers. So, listening to that, do you think that in the end of the day, is health a byproduct of privilege?
I think that health is possible for everyone. And what we show in many other countries, as I was saying, this gradient, so many societies are able to provide healthy conditions for all of their people, irrespective of what they earn in terms of income. It's also true that there's many poor countries like Costa Rica or Cuba or the southern state of Kerala that provide really good health conditions and the health outcomes are really good, despite not being very rich. But in terms of the word that you use in privilege, I think that one of the things is that the UK and the US are doing the worst among COVID. You would think that the single most biggest difference is that the UK guarantees healthcare to everyone, and somehow this should make it better for everyone. But actually you see that disadvantage in both countries exists, and it actually shows up in deaths. So we really need to think about what is it that we're talking about in terms of the conditions for health and the abilities to be healthy. In the US, what it is that the lack of health care, access to health care, people are afraid to go to hospitals because they have to pay for it even if they have insurance. So they wait longer before they actually go. That means that their morbidity is much higher and much more severe before they try to get health care. All of that is now showing up in vulnerability to infection. And in the UK, it's the same thing, is that even if you have healthcare, what are the different kinds of things that people need in order to be healthy? But this thing about the distribution, it's very much about disadvantage. So what you call privilege, I would call disadvantage, is that how we distribute disadvantage and how we make certain people disadvantages is actually reflected in who's dying and who's actually more vulnerable.
And what about the definition of the essential workers? I mean, healthcare staff, we are all ethically obligated to keep on doing whatever we're doing, regardless of the threats that we face, to our own safety. Though, of course, on the other hand, it is unethical to send healthcare staff without appropriate safety nets. And this did happen during this pandemic. But what about all the other people out there? What about the vendors, the transporters, the delivery workers? So, in a sense, does society force its workforce to choose between life and livelihood?
Absolutely. We do this all the time, not just during the pandemic. I mean, what we have to recognize, and I hope that everyone recognizes, is that the kind of work that you do is very much reflects the kind of health that you have. And there's lots of people that end up doing work that's not healthy for them, but they have to do it because that's the way that they have to survive because of a variety of different reasons. This pandemic has really done something quite significant, is that certain groups of people without their choice have suddenly been considered to be essential workers. It would be one thing for doctors to have chosen their profession, knowing that at times like this, they will be needed to go in and take extra risk. But if you were working at a Tesco, no one told you that the job might involve taking extra risks during a pandemic. I think that we have to really think again about how we think about people who do what we call essential work or low-paid work. It's these people, the people that have allowed us to keep having our food, our telephones, our sanitation is picked up. All these people have made us possible for us to stay home and be safe. So we really need to think about, well, what are the protections that we give them in normal sense? What kind of appreciation do we give them, and how do we treat them? So we really need to think about status in society as being distinct from how much you get paid from that job, or we need to start paying them more and actually show them that they're really important.
So, first of all, thank you to everyone that has been working during this pandemic. And in fact, I think that's the biggest proportion of society. So regardless if you're stuck at home or, you're putting yourself, out there doing whatever you're doing to keep society going, thanks. But let's travel now a few hours down south to Greece. And let me take you inside a church, an Orthodox church, where during the service, bread and wine are changed into the body and blood of Christ, which then believers receive as communion, which is given in a spoon, meaning that the same spoon is being used by usually hundreds of people at a time. To me, this sounds like a proper pandemic nightmare, as you can imagine. Now, when the virus broke loose, there were significant pockets of society, including, highly esteemed political and scientific figures back home in Greece, suggesting that the virus could not be transmitted through communion as it was holy and sacred. So how are freedom of speech and free will relevant to this pandemic?
Yeah, so I think that in any infectious disease outbreak, whether it's an outbreak, epidemic, or pandemic, there's always going to be situations where people feel as though their liberties are being constrained by the efforts to contain the pandemic. In this particular example that you've given, it's actually misinformation, because what they're saying is that God will protect us, we don't have to do anything differently. But I think that as people who care about public health and who want to protect the health of our people, we definitely have an obligation to contain infections and actually to restrict certain kinds of behaviors. There have been examples where individuals say, you know what, we will take the risk, but what we value is practicing our religion, and therefore we want to keep doing it. So at that point, what comes into play is whether their freedom to exercise their religion or their speech actually is harming someone else or not. If they are, then we actually have some justification to interfere. But if they're not, if they actually say we are a group of people, we'll be isolated and we will actually not harm anyone else and we will do what we want to do, then we have to, I think, in a good society, respect that. Here it's very different, because they're not saying that we are a small group of people. What they're saying is that keep doing what you're doing and it's going to protect us. That clearly is not a good enough justification.
Okay, so I mean, if there is one thing that we learned from this pandemic is that no one was ready. Not that we didn't know, it's just that governments value more saving banks rather than lives. I mean, we live in this surreal world of offshore companies and tax havens, a world where Richard Branson, with billions of fortune, has not paid tax for 14 years here in the UK, yet has the nerve to request for governments to bail him out. So yes, we were not ready. Inadequate testing, inadequate protection, and the list goes on. We heard horror stories of shortage of ventilators, and essentially doctors having to take extremely difficult decisions of who lives and who dies. Now, of course, everyone is focusing on finding treatments and vaccines, and there is no doubt that when this happens, these are likely to be available first in the countries that can actually afford to purchase them. And only then will they trickle down to low-income countries, where again they will reach first the wealthy. So how can one build an ethical framework for allocating scarce resources?
Yeah, so that's a really great way of phrasing it. I think that because you're Greek, you have a very personal first-hand experience about what this could mean. I think first, we shouldn't say that no one was ready. I think different countries were ready in different ways. In fact, there was something called the Global Health Security Index, which ranked countries according to how prepared they were. And so, believe it or not, the US and the UK were ranked the top 1 and 2 of it. So something went wrong in that, which is that, so you might have all the facilities ready, but if the leadership is not, then it means nothing to it. So we really need to relook at, so this is not just about pandemic preparedness, it's about crisis preparedness. So think about it as which societies are best prepared for a social crisis or an emergency. And we can see that in the way that different countries are doing. And so you can look at the numbers again and say, who's got the numbers that show that the government was able to respond very quickly and to be able to allocate the right resources, to be able to produce trust in its people, to be able to put out clear and relevant information. In terms of what the fair way to allocate resources is, this pandemic has provided us a new kind of problem. Before, in, say, for example, HIV/AIDS or something else, we have this really important good like drugs that will save people's lives. And so we think, okay, what do we do about distributing among people who need it and who can't afford it? In this pandemic, there's a second problem, which is that if people are vulnerable and sick, it'll come back to us, right? So it's not just that we're giving people drugs that they can't afford, it's that we have to do it in such a way that we actually ensure that the worst off who are vulnerable also get the drugs or the vaccine or therapeutics, because their vulnerability actually puts the entire world at risk. So it's this problem about shared vulnerability and how do we distribute fairly that's actually going to be sort of the problem. But I have to say that everybody should already know is that there's already people in conference room who've decided these rules. So someone like you who's Greek probably understands when somebody else somewhere far away decides what happens in your country. So already, we have, when the Europeans raised about 8 billion euros for this fund for vaccines and research. So they put Gavi in charge of vaccines, they put the Global Fund in charge of testing, and Unitate in charge of therapies. Somebody has already figured out, or has already decided, this is how we're going to distribute it. But we don't know what that is. We don't know what the transparency is. But I think that's one of the biggest questions that we're going to face in the future. How did they decide, or what rules are there to protect all of us, but also ensure that it's fair in terms of who gets it, and the worst off get the access to the meds as well?
I mean, now everyone, obviously, we do hope that at some point we're all going to get out of this mess, which certainly is not going to be an easy process. Now, several countries have indicated that they will implement certifications that a person has contracted and recovered from COVID-19, or in the future, when we have the vaccine, that they had indeed received a COVID-19, vaccine. So the so-called immunity passport. I smell trouble. So are there any pitfalls around these passports?
Absolutely. I mean, I think your intuition is right, is that on the one hand, we have to get a way out of this lockdown, because you can't put it indefinitely, because the quality of life of many people has decreased. People need to keep their education, people need to work, people need to get their health care. The immunity passports, what it's trying to do is trying to identify people that already recovered from the infection, so they can then go on and sort of continue with their lives. The problem is that there's lots of people that want to get out of their lockdowns because they need to. So they need to go back to work so they can earn some income. So imagine the perverse incentive of actually trying to become infected so that you recover, so that you can get a passport. So they're taking on this extra risk. So how do we make sure that immunity passports aren't actually advantages that some people get, versus other people feel disadvantaged of it? So we have to figure out that the immunity passport doesn't give you extra benefits that you would have as being recovered versus that. The other thing is that human beings, unfortunately, love inequality and status. And so these immunity passports will be another way that people can use in order to differentiate themselves from other people. And so I worry about that too, is that just in terms of even now, if you think about how people are trying to separate out, oh, those people are at high risk, I'm not at high risk, those people are dying, I'm not the one that's at risk. So imagine what these passports and how people might, start trading in, immunity passports. So there's lots of different difficult problems.
You know what? I was reading a really interesting article in the New York Times recently, saying that in fact pandemics typically have two types of endings: the medical, which occurs when the incidence, and death rates, plummet, they go down, and the social, on the other hand, when the epidemic of fear about the disease wanes. So my question is, I'm wondering, who gets to claim the end, to say it's done, we're out of the pandemic?
Yeah, that's an excellent question. I think that what we right now have is a mentality that the vaccine will end the pandemic. So everybody thinks that if you just find a vaccine, then we basically have a solution, and then it becomes just a problem of implementation. I am, as you can imagine, not very convinced that science or natural science is the solution to this problem. Is that we've revealed so many different weaknesses in our society that even when we get a vaccine, we're going to have to address so many difficulties in our societies and inequalities and weaknesses, that I think that while the scientists and the vaccine makers might say we've cured the world of this pandemic, I think the social end will not be anytime soon. I think that's going to take a long time. And this idea of a threat, a pandemic threat, is going to be more. It doesn't suddenly disappear. This is one coronavirus, not the coronavirus. And so there's many other coronaviruses that are possible, and many other worse epidemics that are possible. This is not the worst epidemic that was possible.
Wow, okay. So what do you think then that the healthcare landscape would look like post the pandemic? And what do you think, are there any other issues that you will be faced as an academic philosopher?
I think that one of the most important issues that any country, particularly the UK, will face is, why did these people die, right? So what is wrong with our health system and our healthcare system that It's not, it was disproportionately older people and minorities and minority health workers that died. And these are all sort of very big patterns. So there will have to be a great reckoning to see how do we change this so that this doesn't happen in the future. I think that's one of the biggest things that will happen in terms of healthcare and reassessing how healthcare is being organized. For me as an academic philosopher, this has just opened up a whole new area of work, right? It's done a couple of things. One is that I don't have to explain anymore what health and social justice has, how they're linked, right? I don't have to explain anymore what global health ethics is. I don't have to explain what public health ethics is anymore. So now the real work begins is actually trying to solve these problems of who do we help first, or what are the changes that we need, or what do we do when our government isn't listening to us or actually have our best interest in mind? What are the ways in which health can be used to justify social change? So those are all big questions that I think that lie before us in the future for academic philosophers.
And now you have one more question to answer. You know, I've been asking this question everywhere, but then it came to me that I've never asked this question to the most relevant person, a philosopher. So in this pandemic, which was, you know, it was another opportunity to highlight the link between infections and mental health, right? So is this pandemic the final nail on the coffin for the mind-body dualism supporters?
I wish it were. I really wish it were, but it's not going to be. And I can say that very confidently because just think about the way that people are talking about it. One, people are focused on the healthcare system, which is basically about protecting the healthcare in terms of clinical care in the ICUs, and they're talking about vaccines. So think about that as being the focus, while I and us are talking about abilities to be healthy. And for somebody to be able to be healthy, they have to have both the mind and the body, and they have to come together. And that's what I've been arguing, and I think you would argue that too. And unfortunately, I think we have at least an opportunity to talk about that, but we have a whole world against us that's basically fixated on, let's find an injection or pill that will solve this problem.
Amazing stuff. That was really mind-blowing, Sri, honestly. And that, sadly, brings us to the end of our Psychiatry of Pandemic series. A beautiful, I would hope, journey that took us from Hippocrates to the Spanish flu and from cytokine storms to health inequalities. A massive thank you to my guests, Drs. Tom Pollack, Jonathan Rogers, and Siobhan G. Our guest from Denmark, Professor Michael Eriksson Benros, and of course, Dr. Venkatapuram. And now you will say, now what? What's going to happen next? Is that all? Of course not. If I was on the stage in Glastonbury, I would be shouting, do you want more? Since I'm not in Glastonbury, I'm assuming you say yes. And if you said no, well, tough luck. Because you're not going to get rid of me, that is. I'm back next week with a fresh weekly program. The concept, exactly the same. 30 minutes conversation with inspiring people that are happy to share their love for whatever they're researching. Always around the most beautiful and mysterious thing we have on our bodies. Our thyroid, of course not. The brain. Open your Outlooks, Evernotes, notepads, and pencil it in. But note a slight change. It's every Monday at 1 p.m. In 2 weeks, I will be traveling overseas, mentally only, to discuss with a psychiatrist from Johns Hopkins University and see how did the United States of America deal with the corona. Next week, though, I'm joined by none other but Sir Professor Simon Wesley, the president of the Royal Society of Medicine and ex-president of the Royal College of Psychiatrists, and to be honest, one of the best all-round speakers, regardless of the topic. You know, you can ask him about, I don't know, about dust, and he's going to make it sound like the most prolific thing you've ever heard. So, see you all next Monday at 1 p.m. Until then, Pospo for Mostly Learning, over and out.